Over to you, Simi.
Uh, Good morning, everyone. Thank you, AIOC, for giving me the opportunity, and thank you, Dr. Vikas, for inviting me as a co-instructor. I will be presenting a few clinical pearls in the management of HSV epithelial keratitis. So, the epithelial involvement can either present in the form of infectious or neurotrophic keratopathy. Those presenting with infectious epithelial keratitis can either have symptoms, can have clinical features in the form of corneal vesicles, dendritic ulcers, geographical or marginal ulcers. So these patients present with symptoms of photophobia, pain, watering, and decreased vision. And when examined on slit lamp, the earliest finding can be a small raised vesicular epithelial lesion, which because is raised above the surrounding epithelium, thus stains negatively, and later these vesicles coalesce to form dendritic or geographical ulcers. These dendritic ulcers are branching linear lesions with terminal bulbs and have swollen borders which harbor live virus. And they have a classical staining pattern where the ulcer stains positive with fluorescein along the entire length of the lesion, while the epithelial margins being raised above the surrounding epithelium stain negative. And when these are when they are stained with rose bengal, they stain positive. So the epithelial borders stain positive rose bengal. A clinical tip here for all the clinicians is that whenever we aim to send the corneal scraping for viral culture, it is better to avoid prior staining with rose bengal, as it tends to inhibit HSV and thus can yield a negative report. And the clinical staining pattern helps differentiate the typical dendritic HSV lesion from various other pseudodendritic lesions, which can mimic the similar presentation. However, there is absence of terminal bulbs in other causes of pseudodendrites. In patients where these patients with dendritic ulcers, when are treated with topical corticosteroids or are long standing, then dendritic then their dendrites tend to merge together to form a widened lesion, which is called as geographical ulcer, which have scalloped borders and have longer duration of symptoms. These needs to be differentiated from neurotrophic epitheliopathy, as those lesions will have smooth borders instead of scalloped borders. Coming to marginal ulcers, where the epithelial ulcer will be associated along with stromal cellularity or stromal infiltration because of intense limbal injection adjacent. There is absence of lucid interval, and these, when progress, tends to progress centrally towards the visual axis, which is as opposite or as opposed to any other cause of bacterial blepharitis, where the progression happens centripetally along the circumferentially along the limbus. Uh, another another entity is neurotrophic keratopathy, where it is neither infectious nor immune, but instead is because of the impaired corneal innervations and decreased tear secretion. And these present in the form of irregular epithelium and lustreless cornea, and eventually will develop an epithelial defect which have oval and smooth thickened borders. Uh, Talking about some treatment pearls is that the dendritic or geographical ulcers, the main aim of treatment here is to get rid of the live virus. And the mainstay of treatment is topical antiviral agents, where we can either use acyclovir 3% or ganciclovir 0.15%. And they bind to DNA polymerase and acts like a chain terminator. The eye ointment Acivir is to be given 5 times a day for 21 days. And if the patient is severely symptomatic because of the epithelial defect, then topical cycloplegics can be used to relieve ciliary spasm. Also, prophylactic antibiotics can be given 3 to 4 times a day for large geographical ulcers, just to reduce the risk of secondary infection. And lubricating eye drops can be given for large ulcers. There is a study by Kolam et al. Where they published that oral acyclovir is as effective as topical acyclovir. The indications here are that they can be supplemented in cases with precious grafts. However, they can also be considered, oral acyclovir can also be considered for compromised ocular surface, as well as those patients who are intolerant to topical acyclovir. Having said that, in the clinical experience, these are very well tolerated and are not so toxic to the ocular surface. The duration of treatment is to be 5 times daily for 21 days, even when you have seen that over 4 5 days or maybe a week, the dendritic lesion or the epithelial lesion has healed. And longer periods may be needed for geographical ulcers. The role of topical steroids is strictly contraindicated when you are dealing with active dendritic lesions. However, it can be supplemented when there are anterior stromal cellularity along with the dendritic lesion. However, when the dendrites are in the resolving stage. Talking about the management of the neurotrophic keratopathy, here it's better to stop the antivirals and give the patient with intensive lubricants 1 to 2 hourly. Also, along with that, a prophylactic antibiotic to reduce the risk of secondary infection. And the mainstay here is to do a tarsorrhaphy for the persistent epithelial defects or ulcers. In case it doesn't heal, then it can be supplemented with amniotic membrane grafting. This is a patient who had come with a persistent epithelial defect post HSV keratitis, where we did a tarsorrhaphy, and 2 weeks post tarsorrhaphy, the epithelial defect has healed completely. This is another patient with neurotrophic ulcer, which started showing the signs of healing 5 days post tarsorrhaphy and eventually healed 3 weeks post tarsorrhaphy. So again, in conclusion, in patients with neurotrophic keratopathy, tarsorrhaphy along with intensive lubricants play a very important role. Thank you.